everybody. As you know, it's Susan, speech therapist. I'm going to talk about two main things, swallowing and cognition. So let's go look at the screen here. And you see this is an animation of the typical swallow. The teeth, well, here's the nose, the lips, the chin, the back of the neck, the front of the neck, right? The hard palate on the top, the mandibular bone, and this is the tongue. This big muscle here is the tongue. Okay, this is the trachea, where we breathe, right? The air comes in and out here, out of our mouth or out of our nose. This right here is the beginning of the esophagus. So that's called the upper esophageal sphincter, that muscle, and that's the esophagus. This is considered the oral part of the swallow. This is considered basically the pharyngeal part, maybe here, part of the swallow. This is considered the laryngeal area where your voice box is. These are the vocal folds that produce your voice. Sorry. I hope it doesn't do that too many more times. And then this, like I said, is the beginning of the esophagus, and that's the beginning of the esophageal stage of the swallow. So you have three stages: oral, pharyngeal, and esophageal. So I'm going to run a typical swallow animation. The white part is the bolus. Bolus can be food or liquid or medication. Here we go. Okay, so now I'm going to do that again, more slowly. And you can see it again. Whoop. So obviously the bolus is going in the mouth, and they're chewing. I'm going to stop here. So the way swallowing works is it's all about pressure, intraoral or interpharyngeal or intraesophageal pressure. So it's our muscles make a space, a very, very tight space with where no air can leak through. So then once your body creates that space, it then begins to contract and tighten and the front part of that space, which increases the pressure, which moves the bolus in whatever direction it needs to go. So in this stage, you can see the uvula, that thing that hangs down the back of your throat, is connected very tightly to the back of your tongue. So there's no way anything's going to get down there prematurely. And it's chewing, chewing, chewing. And then you see the tongue comes up. Of course, every swallow process is a little bit different, whether the lips come together or the tongue comes up. So now what have we got? An incredibly tight space. So what's going to happen is this is going to begin to relax, and this is going to tighten, which will move the bolus down that way. Tight, 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 open. So here everything has come together and tightened. The uvula, that thing that sticks down the front of in the back of your throat, also called the soft palate, has come up, and it's met with the top back of your throat, or the pharyngeal muscle in the back. That's obviously so that nothing goes into the nasal passages. Sometimes people have a little bit of problems with this, and it doesn't quite connect well, and sometimes food and liquid kind of goes up there, and that's why sometimes when people are eating and they have dysphagia of some sort, they will sneeze a lot, because it's tickling and stimulating that sneeze reflex. So here it goes. The back of the tongue has sort of flattened. The uvula's gone up, and it's going down. Now I want you to look at this line. This is the whole line, the back sort of muscle of the pharynx. That's going to be very thin until at one point, and then it's going to get very thick. So you see the tongue is now meeting with the top palate. It's pushing everything down. And it goes like this. So now the tongue's come up. It's met with the soft palate, right? No space there anymore. This has opened up a little bit. It slid down. And again, I want you to look at this muscle. That's, as the bolus comes down, the white, see, that sort of contracts or expands, whatever you want to call it, and meets the back of the tongue. So that makes sure that no food stays there and it's going to head down. Again, the back of the tongue is making more and more contact with the pharyngeal wall. And there it goes into the esophagus. So the esophagus, you'll see here, is opening and letting it down, and then it closes. As soon as all the food's down, it's closed. I'll talk about this area in a second, but just to explain that this trachea, where, you know, the opening that we breathe through, is never, ever, ever, ever closed. It's protected for a second when we swallow, but otherwise it is always, always open. The esophagus is always, always closed until the swallow reflex happens. Then it opens and then it closes again. If you have problems with that sphincter not opening and closing or staying closed enough, then you have problems with reflux, where that's gastric juices come up, and they can be very irritating to the lining here. Okay, so we're going to go back to this stage. And this is really important. This is called the epiglottis. It's just a floppy cartilage, soft. And before the food gets down, the larynx, which is this area, remember this is the voice box and this is the top of the trachea, that has to get away. It has to get away from the food path, or the path of the bolus. So remember, it never really closes. It just moves and gets covered. So if you notice, when the food comes down, this is going to go up and forward. Up and forward. Okay? So here's the pathway of the food. Your larynx, that's when you see the Adam's apple. When people, men especially, swallow, you can see their Adam's apple goes up. That's the thyroid cartilage, and that's what's being moved up and over, up and over. So remember, it's never really closed. That's why there's always a little bit of a problem with people who have dysphagia in terms of aspiration. This, like I said, is the epiglottis, and not only does the larynx move up and out of the way, but the epiglottis flops down and covers it. See? Boom, there it is. It's actually bigger and thicker than it looks here in the lateral view. And the food slides down into the esophagus. Okay, now I'm going to show you an example of a swallow that doesn't work quite so well. And you're going to see the bolus is going to come down. It's going to sort of have some residue here, and it's going to get stuck in this follicular sinus, and I believe it's going to go into the trachea. So let's make it a little bit faster, and this is what this looks like. And boom, went into the trachea, and now the person's coughing. Okay, so we're going to do that again, just a little bit more slowly. So the same thing here. Where is it? There it is. Okay, so you see there's still some here. Remember in the north, so the pharyngeal wall's moving nicely, but the uvula isn't quite up enough, and the tongue obviously isn't contracted enough. So you've got residue or stasis here, while, you know, this stuff is happening here. So it got stuck here. It's lining the whole tongue. It got stuck in the vallecula sinus, so the epiglottis. Let's see what happened with the yeah. Okay, so so there's a big space here. There shouldn't be a space there. Bam. Right, and because remember the larynx is supposed to go up and forward, and it didn't really do that. It did it somewhat, but not completely, not as fully as it should have. So because it didn't really move out of the way, the epiglottis didn't invert completely. It only partially inverted. And so you've got food like slipping here and there. Look at all this residue along the tongue. And that's why I'm always looking in people's mouths, because if there's residue in the mouth, there's a very good chance there's residue all along here as well. Okay, so it spills. So now the larynx is back in its normal position. Remember the top of the trachea. The epiglottis is no help because it's back in its neutral position. But food is still hanging around here, so naturally it's going to drop down into the trachea. Some of it's going towards the esophagus, some of it's stuck there, and some of it's going in the trachea. And the person's struggling and trying to cough it up. Okay. So that's good, right? Stop it there. So now you have a little bit of a sense of how swallowing occurs, the process, and I'm going to talk about very quickly 3 ways that we can make the swallow process happen more safely, more efficiently. One is, as you all know, a little lubrication goes a long way. So that means extra sauce, mayonnaise, butter, cream, all that stuff. You have heard that from me so many times. The second way is a really important way, and that's positioning. So you can imagine, now that you can visualize what happens internally, if someone's like this, it's going to make the whole process harder for them. Not for sort of a younger, healthy person, but for an older person, it has a huge impact. So we can affect their posture in a few different ways. One is what the item that they're sitting in. Obviously, they can't be in bed. It doesn't give them enough support, and they will never get to a nice upright position when they're in bed. If they absolutely have to be in bed because they really, really, really refuse to get out, despite your sort of gentle coaxing and education, or they're medically unable to leave the bed, then give them tons of postural support, right? Lots of pillows and things beside them, and get the bed up as far as it will go. Sometimes if you put it up, they don't like it right away, but if you put it up a little bit, do something else, and come back, you're able to put it up a little bit more. They shouldn't be in the recliners, those wonderful recliners they have in their chair, in their rooms. Those aren't good. Again, same thing, it's too far from the table, and they can't really get good upright positioning in them. So definitely the policy here is to get them out of the recliner for their meals. Again, try really hard in a gentle way to get them to do that. Tell them when they're done, they can go back to the recliner. Besides the fact that it makes for unsafe eating, when they're in that recliner too long, that's not good for their muscles at all and their skin integrity, etc. So ideally they should eat in a straight back chair. The second thing is the table placement. So the table really, really, really has to be as close as possible for the large majority of the people here. So if they are in bed, when you put the over the bed table, I see it all the time. It's just not close enough. It has to be as close as possible. The height of the table should be around elbow height. So those are the 2 things that I see often, although not as much as I used to, but I see often the table isn't close enough and the table is a bad height. It's either too high or too low. The second thing that we can do to help posture and help their good positioning is where we put stuff on the table. So sometimes just moving the plate or the bowl a few inches closer to the edge of the table can make a big difference. They won't be hovering over it to reach it. A lot of them feel very nervous about spilling, so if the plate's closer, there's less a chance of spilling, and they know that. The other thing I'd really, really love to see is more drinks placed near their dominant hand. So if they're right-handed, put at least one drink, at 3 o'clock in the place setting. Some people won't like that. They only want the cups and the utensils and the dishes exactly where they're conventionally supposed to be, and that's fine. But do try. I think dehydration is a problem here, ongoing problem, and I believe that one of the reasons is they can't reach the glasses, or they're just a little bit out of their attention field, their visual field, or it's just too much effort, or they can't really see it, who knows. But you can do a big service to them by just placing one drink close to their left or right hand, whichever is dominant. And the third way to help people swallow more safely is the obvious things that I know so many of you know. Encourage them to take small bites or cut their food so that it's in small bites. Encourage them to take one sip at a time. Encourage them to eat slowly and not to talk while they're eating. Another main thing I want to talk about is what to do when someone's coughing, aspirating, or choking. Coughing means some type of food or liquid has gotten too close to the airway. Aspiration means it's gone into the airway, and choking means something's gone into the airway and has blocked it, so there's no air exchange. When someone's coughing, you know what coughing is, and they might turn a little bit red, but they're coughing and they're working it out and they're swallowing and they're breathing. You can see that. When someone has aspirated, they're going to turn very red, maybe even bluish. Their eyes are going to water, possibly, maybe some nasal discharge, and they're going to have a look on their face of alarm and usually pain and discomfort. Choking, obviously, there's no coughing, there's no voice. You can tell they're not getting oxygen. What to do? In any of those situations, watch them, be quiet, be still. Don't rub their backs, don't pat their backs, don't talk to them. Their body is in a state sort of alarm right now. We don't want to distract them, either tactilely or vocally or visually even. Just be near them and watch how they manage it. Don't give them a drink. Let them work it out. They have to stay as relaxed as possible. If we touch them and say things to them, are you okay? It's just making everything a little more confusing for them. You can, sometimes if people are really coughing for quite a while, or if they're ready to spit something up, sometimes things get stuck in the esophagus and it goes up and down and they're not sure and then they end up spitting it out. You can place a firm hand on the lower back just to kind of help them lean forward. Again, no rubbing, no patting. Look at their respirations. Don't resume feeding unless their respirations are back to normal, skin color's back to normal, they can speak, and they're back in their normal state. Then, before you kind of let them eat again or begin to feed them again, check the things that we've talked about. Check that their posture is optimal. Check that the table and the chair are placed as close as possible. Check that maybe there aren't too many items in front of them, just put a few items in easy reach, all the while watching their breathing. Then maybe you can resume feeding. Obviously, if they had a bad aspiration or choking event, then maybe don't feed them again. You can try to feed them again, though. If you make that judgment, feed them food that's really easy to swallow, and maybe they'll go through the rest of the meal without it, and that's fine. Definitely report it to the nurse, though. But if you resume feeding again, or you kind of watch them again and they're feeding themselves again, and something like this happens again, then they should probably stop eating and stop the meal and tell the nurse. Okay, I have a couple of other miscellaneous items. So modified food, right? It's either chopped or ground or pureed, and we all have had long discussions about benefits and difficulties of this kind of food, and we're always, all of us are always weighing quality of mealtime experience with safety and independence of feeding and all those things. And it's really pretty interesting. It's complex, and we try to make it as individualized as possible, and I always appreciate CNA's input. You guys are amazing in terms of your observation skills and recommendations. Nobody could handle this without everybody's, input. I do want to ask that when you're presenting food that is chopped, ground, or pureed, or different in some way, that if you could try to always present it positively, have a positive attitude, and use positive language. So, oh look, this is some smooth, some thick soup for you. This is going to be really yummy. This reminds me of comfort food that my, grandmother used to make, or this is actually really tasty. Someone told me they had it, yesterday, or it's, in a way, I know you've been taught to tell the person what they're eating, which is great. But sometimes if you say, this is steak and green beans, and then, they're putting something pureed in their mouth, it doesn't make sense to them as it wouldn't to anybody. So what I sometimes say is, this is a steak recipe, or this is like a thick soup and there's steak and beans in it. Something like that, so that they're ready for the textural experience of the food, because it's going to be very confusing to them if you call it something and they're expecting a certain texture. Let's see, this is a minor, it's an important point, but it's a little miscellaneous thing that I'll talk about later. So a lot of how we perceive things, we as human beings, depends on the language we use. And I'm going to talk about that more later. But one of the things I want to say is, it's very old school, old medical model to call a human being a feed, somebody who needs total assistance with feeding. So think about it. I can't say don't use that word, but that word tends to, without a doubt, kind of, even though the person who calls somebody a feed, or the feeds are at this table, or so-and-so is now a feed, I'm sure their intentions are good. They don't mean to say anything kind of cruel, but if you think about it, it really objectifies them. It's depersonifying. It's, like I said, old school, old medical model to see someone and think about them first as a diagnosis and a disability, rather than a human being first. So, of course, that's what we want, the latter. So we want to say, so-and-so needs full assistance with feeding now, rather than calling them a feed. Second or last issue having to do with feeding and mealtime is, we've talked a lot about putting minimal items in front of them. So that can help with decreasing confusion for somebody with dementia. It can help with helping people make sense of what's in front of them who are visually impaired, really low vision. It can help people who have dexterity issues. They're going for something, but there's all this other stuff around them. It's hard to pick it up. And it can also help people who have appetite issues. As you know, low appetite and not really interested in food. If there's too much in front of them, it's a turn off. So, as I've said to you CNAs before, use your judgment. You have full reign to go and grab a dark napkin and experiment with that, or experimenting with putting less things in front of people and see what happens. You really, really do know best in that regard. And then just let me know, or Penny, or the service, and let us know your thoughts about that. And we can put that into the care plan. The second big part of this in-service is on dementia. Dementia is hugely complex, individualized condition, which you guys know better than anybody. Every person's cognitive profile is unique. So let's look over here, and you'll see this is, I'm sure you've seen this kind of diagram before. This is a cross section of the brain, the ears on both sides, a healthy brain and a brain with Alzheimer's. Alzheimer's, remember, is just a type of dementia, the most common type. There's lots of different types, but in this case, this is a good representation of most people with dementia. So the cortex is this, the outer part of the brain. And as you can see that here it says it shrivels up and it just kind of atrophies, or the nerve cells die. And that part of the brain is what helps us think and plan and remember and make problem-solving decisions and all that higher order processing, especially in the frontal lobe, which really gets affected by dementia. The hippocampus is around here, that's in the middle, and that involves short-term memory, new things, new information that comes in, and then it processes it and stores it. Not old, long-term information, but new information. And then these are ventricles, which you have a little bit in the normal brain, but here you have lots of space. So sometimes it's really good to sort of get this image in your head and know that when you're really if you're really getting frustrated with one resident, know that if you had his or her brain, you'd probably act very much the same. So even though dementia is very unique in everybody, every individual, there are two things that you can be sure of. One is poor rationale. So it negatively affects their ability to reason and to understand why. So why am I waiting in the hallway? Why do I need a shower? Why do I have to take these meds? Why am I here? Those causal relationships are all affected by the cortex of the brain, which is eroding and deteriorating and disappearing. Add to that the short-term memory deficit, and you've got a big problem, because someone's already explained to him or her why they have to take a shower and why they have to use this walker. And they might have sort of reasoned and understood it then, but then, a little bit later it's gone. So poor rationale, a problem with anybody with dementia. The second thing that's very, very common with anybody with dementia is what they call emotional sensitivity. And that's what I want to talk a lot about, because it's actually something that we can use to our benefit and to their benefit. So people with dementia often have heightened emotional sensitivity. That means they're feeling their emotions very strongly, and they're perceiving your emotions very strongly. So rather than acting according to what they're thinking, they're acting according to what they're feeling. The amygdala is a part of the brain that's responsible for our emotions, our feelings, our instincts. That generally is unaffected by dementia. So if all kinds of information is very confusing to them, what they're seeing, what they're hearing, the language, how they think about things, but the emotions are very strong and untouched by dementia, then that's kind of what they're going to pay attention to. So it's like when you make a decision with your gut. That's what they're doing all the time. So taking these pills doesn't feel right, I'm not going to do it. This person's making me nervous, I'm out of here. This room is creeping me out, I don't know what's going on, I'm leaving. Or something positive, that sun looks beautiful, the trees look beautiful, I'm going. So that's why you have to think when if someone with dementia says something that's really wrong, you really shouldn't think about reasoning with them and arguing with them. You'll not likely win, and you'll only make them more upset, so their emotions get stronger, and then it's even harder for them to use the little reasoning that they have. So let's think about practical applications. How can we use this information to make our jobs easier, make our lives easier, improve the care we give people with dementia? The answer is really pretty simple. Because they're so affected by your mood and your intent and your emotions, you can capitalize on that. So basically, before you do a task with them, it will probably go a long way if rather than coming in and saying, "Hi, it's time to get up, let's get you dressed," if you can have that little social discourse like, "Hi, Mrs. So-and-so, how was your sleep? You know, you look so comfy here. Let's open the blinds. How's this? You know, I'm noticing a picture of your son here. Isn't he handsome? A nice comforter you have." I mean, you can talk about anything. And when you're doing that, you're setting the mood, you're setting the tone, you're getting their emotions in a place that's going to make them more receptive to whatever you want them to do. They read your intent and your emotions just like we do. They look at your facial expression, they look at your tone of voice, they look at body language, gestures. So they're really, really good at that. And the other thing is to remember when you're making that social chit chat with them, even though you're talking about their hairdo or their fingernail polish, what's really underlying that is them thinking to themselves, "Are you a good person? Should I trust you? Should I go with you? Are you kind?" And you're saying to them, "I'm a good person. I care about you. I have good intentions." That's what underlies the social chit chat, which has to happen many times in the day because remember, they're kind of forgetting things. So here are some concrete recommendations. Make that emotional connection before you start the task. Never approach from behind or from the side. Straight on with good eye contact, but again, not too fast. Always introduce yourself. "Hi, it's so-and-so." Give your name all the time, no matter how well you know them. Don't speak quickly. And the other thing is narrate what you're doing. "I'm going to unlock your brakes now. I'm going to move you a little bit over here. Let's turn you over here. Okay, now I'm going to have you stand up a little bit. I'm going to put my hand." Just narrate what you're doing all along. Number one, it makes them know kind of what's coming. But number two, when you narrate, you're using your voice, which again is communicating really good intent. So using your voice is a good way to keep the emotions and the mood positive. Okay, I just want to talk a little bit about, let's see. Yeah, so there are many reasons why people with dementia sometimes act out, yell out, get agitated, as we say. And what I would like to present to you is that, and this isn't my thought, this is in the literature, is that we have to stop thinking that, "Oh, she's acting out and she's being aggressive and he's being agitated because of the dementia." It's not always because of the dementia. Sometimes it's because of the environment or the way someone interacted with the person, even if they had good intentions. Sometimes it's something that we are doing, and it shouldn't be always considered a function of their organic brain disorder. We have to look more closely at how we're interacting. So for instance, if a resident gets taken out of a room, she gets wheeled into the dining room without being told or asked, she gets food put down in front of her, maybe people are telling her, but maybe she doesn't really hear it and they're not making eye contact and they're rushed. Someone starts to cut her food, all of a sudden she yells out and she protests. You could understand that if you see it from her perspective, that for the last half hour she's been kind of pushed around here or there. People with dementia are fully capable of feeling disregarded, disrespected, alienated, ignored, and depersonalized. If any of us is confused long enough, we're going to get angry. And if any of us is angry long enough, we're going to get aggressive. Or anger sometimes drawn inward, I guess they say, you can get very, very depressed and isolated. So again, that social connection, that social chit-chat, and that narrating very gently what you're doing helps minimize that confusion and helps minimize that negative cycle from confusion to anger to aggression. Okay, so I'm going to talk a little bit more about the language that we use. So not only should we be mindful of the language we use when talking to residents, but I'd like to propose that we think a little bit about the language we use when we talk to our colleagues or coworkers about residents. For everybody, language affects the way we see things, and how we see things affects our behavior. So language affects perception, perception affects behavior. If we use certain kinds of language when we're talking about residents, everybody who hears us will see that resident in a certain light. And you really have, everybody, we all do, have a lot of influence over how we all approach that resident and what we expect from him or her, and how that whole interaction goes. So here's an example. If someone says, lately Mrs. So-and-so has been calling out and refusing care. You hear that a lot, right? We're going to see that as it's obviously negative behavior, she's being resistant and difficult. We're going to approach her with our back up a little bit and kind of ready for conflict. That affects our sort of emotional content of our language and our body language when we approach her, which remember is exactly what she's perceiving, way more than the words we're using. She's thinking, her attention is on how you're saying what you're saying. What if someone described Mrs. So-and-so in this way? Lately, Mrs. So-and-so gets really frightened and upset when I try to help her dress. I think she feels like I'm going to hurt her. Or maybe she feels like she's being bossed around too much. You're probably going to approach that person a little bit differently with that description. Here's another one. Whenever we try to bring Mr. So-and-so into an activity, he gets aggressive and he tries to get out. He knows he's not supposed to stand up, but he does it anyway. Or you could say something like, whenever we try to bring Mr. So-and-so into an activity, I think he starts to feel coerced and trapped. He almost panics. He doesn't trust anyone to help him and does everything he can to get out on his own. Here's another one. Last one. This new patient is really wacko, way out there. Doesn't have a clue. As opposed to, this person is really struggling to make sense of things and not having any luck. She's trying to ask a lot of questions, but she's not able to express herself, and she kind of keeps asking the same question over and over. I think she's trying to control what's going on because she knows how confused she is. So, again, just something I wanted to, see if you agree with and kind of think about a little bit. Now, I want to say this idea of using a positive mood when you approach, right from the beginning, when you approach a resident, calm, positive, you get them to feel that way, and you also communicate confidence. If you're a little bit rushed, it communicates kind of nervousness and maybe lack of confidence, like they might kind of feel like, does she really know what she's doing? She's rushing around and seems a little uptight. So when you come in calm and confident and gentle and positive, they're going to be much more likely to be, quote, compliant. And I just want to say, this is not some pop psychology recommendation. This is evidence-based, scientifically proven negative behavior reduction strategy for people with dementia. Okay, so in summary, I want to say one more thing about language. I know in a medical setting like this, it's very typical to refer to people by their last names. But again, I just want to challenge you to think a little bit about that and what that means when we say, you know, Gilmore needs a shower, or, you know, McMahon has to sit over here. I can't even really say it out loud, and I think you all agree, it's pretty disrespectful. You wouldn't want someone referring to you in that way. So think about it absolutely when you're in the presence of residents, but also even, you know, when talking to colleagues. There's something about saying someone's name that just their last name that kind of dehumanizes them and makes them seem more like kind of an object. Again, that's one of those things that's an old school medical model practice that a lot of the field and the literature and the research is trying to get away from. So in general, let's try to shift our thinking from a thinking approach to a feeling approach. And let's just remember that they, like anybody, can sense or feel humiliation and anger and joy and fear and sorrow. And they know when they're being treated with respect and when they're not. Just like you and I, they can sense the feeling of compassion and kindness, as well as alienation and indifference. They also know very much when they're being patronized or talked down to. Because remember, it's kind of a scientific thing that human sensitivity is preserved and remains. So thinking on a positive note, to end on a positive note, I had asked some of you, let's see, since people with dementia remind us that we're much more than thinking creatures, no one knows them better than really CNAs. You get very intimate with them. So I asked some of you, what are the human qualities that remain in someone with dementia? And these are the things that some of you came up with. So these are the things that are untouched by dementia: creativity, appreciation of nature, response to music, empathy, emotional perception, nurturing, sense of humor, appreciation of beauty, and sharing warm personal relationships. So I'd like to end with a short quote from Robert Frost, one of his poems. The title is, "The mind is not the heart." Thank you very much.